Hello, everyone, and it's my pleasure to join you today to provide you with a perspective that's clinical primarily on the changing paradigm of care and sort of comment with you on or discuss with you future directions for novel and next generation therapy in myeloma, bring to the table some of the and very important studies that were presented at ASH to give you updates, but then to provide context. And what I will present to you today will complement what you've heard so nicely from Ken, from Cliff, from Omar, from Adam in particular in CAR-T. So in the interest of time, Adam has covered that in great detail. I'm going to spend a little bit less time on CAR-T therefore, and also build on what you heard so nicely from Shonali and Monique. Further, whilst Jad has done a beautiful presentation on amyloid, obviously what I'm not going to cover is any of that because it's its own distinct space. And Irene has presented to you on precursor conditions and smoldering myeloma and MGUS. So my focus is to provide a clinical perspective on the changing paradigm of care and hopefully give you some important insights as to how the field continues to evolve in such a positive and hopeful way. These are my relevant disclosures. So just by way of introduction, it's very important to recognize that multiple myeloma is absolutely not one disease, as its name implies. It's multiple diseases, and thus one size truly does not fit all in terms of the therapeutics that we apply. The complexity of this disease is summarized really in this slide. There's a lot of information. As you can see on the left here, there's a plain radiograph of the skull of a patient showing the classic lytic bone disease that we have come to see as being a hallmark of myeloma. The plasmacytosis in the marrow. This unfortunately represents extramedullary disease in the liver. And this image here conveys the complexity of the genetics that underlie the myeloma itself. And what I show here is that there is tremendous clonal heterogeneity that underlies myeloma pathobiology. And this particular image here illustrates what we call whole genome sequencing, which you heard so nicely from Nikhil from earlier. When this patient receives initial treatment and then unfortunately the disease comes back, you can see here how the genetic complexity of the disease becomes even more complicated and the number of mutations magnifies. So as we think about treatment, we also have to think about mutational burden that's generated within the myeloma. We have to think about immune exhaustion. We have to bear in mind infectious complications and myelosuppression, to think about what impact this has on the end organs of any patient in that context, be it their kidneys, their skeleton, and so forth. And then an important entity, which we call extramedullary escape, which is where the myeloma tries to come out from the bone marrow compartment and involve other aspects of tissue, and we call this extramedullary disease. Now, the important message around genetics is as follows, really. There are some genetics that are what we call high risk, and at the same time, there are actionable genetics that we can actually target with new drugs, such as venetoclax, and we'll touch on this in a minute. So a busy slide here, but a slide that really tries to capture some of the key aspects of myeloma pathobiology. And the good news is that we've got a lot of new drugs to meet all of these challenges. And in this particular slide that we presented last year in a research update just illustrates all the excitement around proteasome inhibitors, immunomodulatory drugs, previous use of histone deacetylase inhibitors, the nuclear transport inhibitors, the antibody drug conjugates, the peptide drug conjugates, obviously the tremendous excitement around CAR-T and bispecifics that you've heard about already. But the critical message is that these drugs critically not only target the myeloma itself, but also critically the microenvironment. And what we've seen with each of these drugs as they've been developed is that first they've been established in relapsed and refractory disease and then brought earlier. And now, of course, we're up to an exciting new space where, in fact, we've got one more agent to add here. We're now at 17 new drugs and multiple approvals, which we'll come to discuss in a moment. And as you heard from Ken earlier, there are three eras of progress: transplantation, targeted therapies, and immune therapies. And these aren't mutually exclusive, but nonetheless, they represent three distinct phases of progress. And in this regard, we're now in the era of combining targeted therapies with immune therapies going forward. And so in terms of treatment targets for our research, this is a slide I've adapted from one of Ken's slides to really make some critical points. We try to target genomic abnormalities. We try to overcome the mutations. The critical role of combination therapy in this process is really important. There's an evolving position of transplant, which you've heard so nicely from Cliff about. And then if we think about the three aspects that really, or the four aspects that really matter in terms of our therapeutics, there's the targeting of excess protein production, which is obviously a hallmark of myeloma pathobiology, what we call targeting protein degradation. Then in the context of immune suppression, how do we restore anti-myeloma immunity? So some very important treatment strategies going forward. Now, a lot of information I'm going to share with you today, but what I want to emphasize is the broad principles, and hopefully by so doing, illustrate the real excitement and progress that we're making. So with that in mind, as I mentioned, myeloma is characterized by an immunosuppressive tumor microenvironment. And so it's very important to try and reverse this process in a favorable direction. And what we've realized is that some of our earlier drugs that we thought of in perhaps more simplistic terms, for example, do they just target blood vessels? We've realized that, in fact, they do exactly that. They do target the immune system way beyond the effects on blood vessels. And this is, of course, referring to the immunomodulatory class of drugs. That's thalidomide, lenalidomide, and pomalidomide. And what we've realized is these drugs actually not only kill the myeloma directly, but above all have a profound effect on the microenvironment within which the myeloma resists, grows, and survives, as well as the immune system. And also, of course, has a smaller effect on the blood vessels than was originally thought, but altogether have really changed the treatment paradigm. And our understanding of the science behind these entities has evolved over time. That in fact, some of our more recent discoveries as to how the drugs work have in fact followed the widespread use of these drugs and their clinical benefit, which I think is an important point of principle. Now, where do we stand then in 2023? Well, this is a busy slide, but hopefully one that conveys really all that we have available and at the same time the excitement of the future. So we have what I call backbone or standard of care agents here on the left. We have recent approvals for relapse disease that are coming through, and then some of the emerging therapies that are very exciting, as well as some agents that have been very recently approved, such as teclistamab, and others such as talquetamab, that will probably be approved in the very near future. Now, when we think of myeloma therapy, I think it's important to share, though, that this disease is truly a marathon, certainly not a sprint. So I'm going to talk to you about the management of symptomatic myeloma, the management of relapse disease in particular. As I mentioned, Irene has obviously beautifully covered MGUS and smoldering, so we won't dwell on that. But I wanted to emphasize the strategic view of the disease, and simply because tolerability and efficacy are key in myeloma treatment. They improve outcome by virtue of also being keenly aware of the impact on quality of life. But we also have to realize the impact of the COVID-19 pandemic. And now, whilst the worst of that is behind us, in my view, I think going forward, we have to recognize that COVID still constitutes a very important challenge and has moved into an endemic phase for our patients and families, and therefore has to be thought of in practical terms going forward. But I think the very worst of it, thank goodness, does appear to be over, and that's obviously something huge to celebrate. Now, what in terms of myeloma therapy should we be thinking about in the newly diagnosed setting? Here, I just wanted to summarize some of the things you heard so nicely from Cliff about earlier. Suffice to say that it's an evolving treatment landscape for transplant-eligible patients. Should they have an immediate transplant, or can it be reasonably kept in reserve? Should it be a triplet or quadruplet combination that's used? And do we use a new tool called MRD to guide our therapy? In terms of transplant-ineligible patients, in other words, for whom transplant would be too toxic or inappropriate to use, the same basic principles apply, triplet versus quadruplet, and just adjust, particularly for our older and frailer patients in whom a BDI on toxicity is absolutely essential. And then I think what's incredibly important is the new directions, the novel immune-based approaches that we'll talk about in a moment, and the novel targeted therapies, which are equally important. So the newly diagnosed landscape is evolving remarkably. You've heard about this both from Cliff and from Ken as well. And going forward, we've realized that MRD as a research tool may be particularly valuable. Perhaps in standard practice too, it can be helpful, at least in the upfront setting. The timing of transplant, early versus delayed, is a key new area of exploration. And then how do these new immune therapies matter when they're brought into this setting? So where do we stand in terms of recommended regimens at this point? Well, I've summarized them here in the interest of time, just to share basic principles. Very great similarities now between the regimens, but essentially they constitute a proteasome inhibitor, an immunomodulator, some steroid, and an antibody. That is typically what we use. And then maintenance consists typically of a lenalidomide backbone with other drugs added as appropriate, be it an antibody or be it a proteasome inhibitor. Now, these guidelines to the right here are the European guidelines, and here to the left are the US ones. What's rather nice is that there's a great deal of concordance between the two now, as our respective advances have been obviously done in partnership. And so novel therapeutics are increasingly available in the European and ex-US settings to a much greater degree than they ever used to be, which is very exciting. Now, when we think about frontline therapy, I just want to show some basic principles here. We have to recognize that myeloma is a heterogeneous disease. We have to note that the patient population is very diverse, so we have to think about multiple different approaches. And at the same time, personalizing treatment decision-making is absolutely critical to improving outcome. So let's talk first a little bit about transplant-eligible patients and focus on some of our own research. In that regard, RVD has been an absolute backbone in our program now for over 15 years. And in that context, we've seen real excitement around its efficacy. The synergy of the combination approach is clearly apparent here, as you can see, where we've been able to, informed by laboratory partners, demonstrate 100% response rate to the 3 drugs used together. And when we added chemotherapy, interestingly, to this, we noticed that whilst there was an improvement in some of the responses, the toxicity increased. The good news is, though, that when you take RVD and tested it in the randomized phase 3 setting, it became rapidly what we consider a standard of care. And this was the so-called SWOG trial, which clearly showed clinical benefit to the RVD approach compared to the control at that time, which was lenalidomide and dexamethasone. We also noted something important, which was that if you have best response, you do better. So this raised the question of, can you do better with a more potent regimen? Can you combine, for example, carfilzomib with lenalidomide and dexamethasone and do better than RVD? Well, we thought that would probably be the case, given that carfilzomib is so much more powerful. Interestingly enough, in a randomized prospective trial, we actually found that there was no difference between the 2 regimens. And why? Probably because, unfortunately, carfilzomib has some of its own toxicities, which make it a little more challenging. So while certainly there may be some benefit for KRD in higher risk patients, RVD remains what is widely considered the standard based upon its tolerability, efficacy, and its partnering with other drugs so successfully. So we're very encouraged by the fact that RVD has become a backbone, and at the same time, KRD remains an important choice for selected patients who may have higher risk. Now, when we think about transplant, there's a number of important points to share, and I know Cliff went into considerable detail on this, and Ken touched on it as well. But suffice to say, we always have considered the use of high-dose melphalan and stem cell support in the younger eligible patients over the last 30 years as a mainstay of therapy. However, as we've seen the introduction of highly active triplets and now quadruplets, that whole playing field is changing. And what we're seeing is that whilst there may be an advantage to early transplant, using it earlier versus keeping it in reserve, the impact on survival doesn't appear to be substantial at all. And in point of fact, there is no difference if you keep it in reserve for patients using highly active 3 or 4 drug regimens, at least so far. So this is very interesting. Now, in our own work, we've also been able to show that when you relapse after high-dose melphalan, unfortunately, sometimes the genetic mutational burden in the disease that comes back can be substantially higher than if you haven't had an early transplant. And so as a result of that, this may explain why, even though there's a gain in progression-free survival benefit earlier, when the disease comes back later, the challenge is then a little greater. So therefore, that may explain in part at least why there is no major survival difference. Now, another important, interesting, and critical point is that there is a rare but real risk of second cancers. And when that occurs, obviously that's something we want to avoid. That does appear to be significantly higher with the use of high-dose melphalan. Now, with that in mind, we launched the Determination study, which we presented and published this last year, in which we looked at the use of RVD early with early transplant versus keeping transplant in reserve. And above all, as Ken touched on, and also Cliff, we looked at lenalidomide maintenance in this study until progression to make absolutely sure that lenalidomide maintenance really conveyed benefit. Well, the very good news is that we showed a dramatic gain in terms of progression-free survival, which we were very pleased to see, about 21 months. But what was very interesting is when we did as an informed analysis to look at events, in other words, toxicities, other issues that could arise with early transplant, we saw this benefit narrow to about 15 months on average of gain. And then when we looked at overall survival, there was actually no difference, even though only a minority of patients in the delayed arm actually have since had a transplant. When we looked at response rates, we saw that they also weren't markedly different for early versus late, and the clear benefit was coming from the use of lenalidomide maintenance in this setting until progression. But if we looked at duration of response, transplant actually did do better. So this was good. This was important, suggesting that in some patients, transplant early may actually be very important, but in others, it can be very reasonably kept in reserve. And what might guide us in those choices is what we call MRD. In other words, if you achieve MRD negativity in the context of a research study and you're on a particular triplet, even if you have just RVD alone versus RVD and early transplant, the outcomes look very similar. So if MRD negativity is achieved, however you get there, that appears in certainly the research context to be very helpful. Conversely, however, if you're MRD positive, we need to think of more challenges to help you, or more treatments, or rather, to meet that challenge. Now, one of the most important things in determination is we took a very careful look at side effects. And what we recognized is that clearly with early transplant, there are more side effects. Also, very importantly, we saw more of these secondary leukemias, although fortunately they were rare. Nonetheless, these are obviously very important considerations in balancing choices. And also, we looked at quality of life. And what you can see here is that with early transplant, there is a big dip in quality of life over about 2 to 3 months of time. But the very good news is that after the transplant has done and dusted and patients have recovered, their quality of life rebounds very nicely. But all of these are important considerations in weighing the choice of whether or not to do an early transplant. And I think the important message here is we now have choices, and that truly one size does not appear to fit all. And in that regard, we've been able to identify subsets of patients who may need transplant early and those for whom actually it can be very reasonably kept in reserve. One thing I just wanted to share with you is that we started this study in 2010 and we weren't able to report on it until 2022 because it took that long for all these outcomes to be assessed and for our patients to actually benefit from treatment and continue to benefit from treatment for many years. So in a sense, this is a wonderful celebration of how upfront treatment in myeloma has improved for the better, because to see a 12-year time period from the start of a study to when you actually can report on it was pretty unprecedented. And certainly in years gone by, we would have anticipated reporting much sooner. The good news is, with all these exciting new treatments, we've been able to improve disease control, regardless of what's done, in such a way that we were in a position to report 12 years after study start, which is remarkable. Now let's think about where we're going in terms of the future. Well, in terms of the future, adding to the 3 drugs with a 4th in the form of an antibody has really resulted in remarkable results. And it's actually increased the improvement in outcome with 4 versus 3 drugs, even if you have a transplant or if actually you don't. So this again reinforces, I think, the point that we can start to think about tailoring treatment choices. Now, you've heard very nicely about this from both Cliff and Ken, but I just want to reiterate something that we're very proud of, which is the Griffin study led by my partner, Dr. Jacob Laubach. Jacob led this with our other colleagues, Peter Voorhees and others around the country, and we were all part of this study, in which we were showed very convincingly that if you combined RVD with daratumumab and combined it with transplant, patients did really well. Having said that, we then also learned that it might be very possible to do this without necessarily doing transplant. And a representative example here is the so-called Manhattan study led by Dr. Ola Landgren. This was done out of Memorial Sloan Kettering. And what you can see here is that without transplant, there was a strikingly high rate of MRD negativity that was quite amazing, in fact. And at the same time, the response rates overall were remarkable. So 100% response rate, 95% of the patients achieved either a VGPR or complete response, and 71% were MRD negative. Remembering that, as we knew from our previous work, if you achieve MRD negativity, the need to rush to a transplant may be significantly less. So this was very exciting. Now, what about the non-transplant eligible patient population? Very important. The majority of patients who have myeloma, the median age is around 70. The majority, therefore, are older and for whom transplant may be less useful. So what are we doing there? Well, I think you heard a little bit about this from Cliff as well in detail, but again, the same principles have applied. The use of the antibodies and the combination with either a triplet to generate better outcome, or in fact, the use of what we could call a quadruplet in that setting. So a couple of takeaways. One, that RVD has performed very well in the older population for whom, for example, carfilzomib may be less attractive, and the addition of an antibody in the form of daratumumab has been particularly helpful. Now, what's very important to note is that we've also developed an exciting regimen called RVD Light. And I want to especially acknowledge my colleague Betsy O'Donnell, who together with Jacob and our whole team led this trial. This has been quite a practice-changing study. So about 50 patients strong. We were able to offer this to patients as old as 96 in this particular study, and able to demonstrate whilst there was some tolerability challenges, they were all mild to moderate, all manageable, and only 2 patients, 4% of the study population, discontinued because of toxicity, which is quite low, very low. And so in that context, we saw excellent outcome. So just to share with you that RVD, which is something of a flagship regimen for us now, has been given in a variety of different forms. And this is a kind of fun slide because it illustrates the point that there is RVD Classic, which is the original way we put it together, the RVD Light that I just alluded to, that was very good for folks who are a little frailer and older. And then there's what we call Premium Light, which is actually designed to be very user-friendly and done over a month, and very effective. And then what we call RVD Ultra Light, which is even more gentle for the frailer patient. So the regimen selection is dependent on patient age, comorbidities, and functional status. So exciting. Now, in the last part of my talk, I really want to focus now on relapsed refractory disease and discuss with you and build upon what you've heard so nicely, both from Ken, Omar, and of course, Adam, about what we're looking at in the relapsed refractory space for when patients' diseases come back and what we can do to help in that situation. So as you've heard, there are very exciting advances with CAR T therapy and so-called bispecifics or T-cell redirecting approaches. But we need to recognize that when it comes to myeloma, especially in the relapse setting, it's all hands to the pumps. And very importantly, for a significant number of our patients, the complexity of CAR T, even the bispecifics, can mean that this is not an ideal choice necessarily for older or much frailer patients. So we need to be able to meet that challenge and meet that need. And there are a variety of opportunities for us to do that. And these include peptide drug conjugates, which we'll come to in a minute, CELMoDs, which I'll discuss in more detail, or so-called degraders, venetoclax, which targets the 1114 I mentioned earlier, and then some other novel combinations, such as belantamab mafodotin and selinexor, and also another exciting new class of drugs called immunoconjugates. So a variety of exciting options. And all of these basically try to take advantage of the immune system and optimize immune function, and by so doing, target the immune system in a way that will then restore disease control by leveraging our effects within not only T cells, but natural killer cells and other key elements of the immune system. So what I've summarized here is the targeting of particular antigens on the myeloma cell by the use of antibodies, the use of immune or restoring immune surveillance. There is excitement around vaccines, recognizing there's a long way to go there, but some progress is definitely made, and preclinically this is very exciting. And then, of course, as I mentioned, we have oral agents that we used to think had lots of different effects that probably had less to do with the immune system, or so we thought, but in fact realize now quite the opposite. They're incredibly important on the immune system, and these include the IMiDs, and of course the CELMoDs, and now also the degraders, as we call them. And we've also come to recognize that proteasome inhibitors, even themselves, can be immunogenic, as well as other agents such as some of the more traditional chemotherapeutics we use and other novel drugs too. Now, the BCMA target has become very important. So I've mentioned to you just before, we have the targeting of CD38 and SLAMF7, CD38 with daratumumab and isatuximab, SLAMF7 with the antibody elotuzumab. There's now this whole new excitement around BCMA or B-cell maturation antigen. Now, you've heard very nicely about this from Adam and from Omar in detail, as well as Ken. I won't dwell too long of it, but just simply to stress, whilst we have now these three pillars on the left, IMiDs, PIs, and monoclonal antibodies, as I mentioned, I would propose that our fourth pillar is the so-called BCMA targeted therapies, and therefore very important. Now, when we look at the relapse setting and how we pull our drugs together, I just want to show you some basic principles which illustrate the point. The same type of treatment choices we make in the upfront setting, they essentially apply also in the relapse setting as well. And when we look at the available agents in relapse refractory disease, there are multiple drugs available, thank goodness. So I'm just going to touch on a couple of those for a moment. If you look, for example, at a combination approach of an antibody, a proteasome inhibitor, an IMiD, and steroid, as we've done in the trial of carfilzomib, pomalidomide, dexamethasone, and daratumumab, led by our colleague Andy Yee, who's based at Mass General. We have a very close partnership with MGH. And as you can see here, the results are very exciting. 95% response rate in relapsed refractory disease, and almost all of the patients at 1 year are progression-free. So this is very exciting. If you need to use a more gentle approach, such as daratumumab, ixazomib, which is gentler than carfilzomib, it's also oral, and Pomdex, this generates also equally exciting response rates approaching 85%, and with high quality seen in this study in particular, led by colleagues in the US. Now, one very interesting and exciting simple oral approach is the use of ixazomib and pomalidomide. And I just want to show you a little bit of details around this. What we were able to do is combine this approach during the COVID-19 pandemic at its worst. And what we were able to show is this all-oral effect, or this all-oral combination, was really exciting. It generated a median progression-free survival, which means on average, most patients enjoyed over almost 2 years of disease control with just these three pills, the ixazomib, the pomalidomide, and the dexamethasone. And because we have to compare to standards of care to be sure we're not kidding ourselves that we're making a difference, the control arm, who could then go on to receive ixazomib if for any reason they progressed on the Pomdex, you can see here that in fact Pomdex itself lasted about 7.5 months. So this more than doubled when you added the third drug just for 3 pills. So we were very pleased with this study, and we had no COVID deaths at all during this whole trial, which we actually enrolled many patients on during the COVID-19 pandemic at its worst. Now, to build on that, there are other platforms. I've talked a lot about daratumumab. I do want to mention isatuximab, which is an antibody that targets CD38 and has some important qualitative differences to daratumumab. We think both are fabulous antibodies. The point simply is that isatuximab combined with Pomdex maybe have some subtle differences that make it a better combination potentially, but we don't know that for sure. And so nonetheless, if you've had daratumumab, for example, in initial treatment, the use of isatuximab later may be very reasonable. Suffice to say, this very simple combination was strikingly superior for the 3 drugs versus the 2, and this obviously led also to its regulatory approval. Another antibody we're very happy with is elotuzumab, and when you combine this with pomalidomide and dexamethasone, you can see substantial clinical benefit. Now, what about some of the more recent, newly developed drugs that are basically coming to the fore in the relapsed refractory space? So I want to spend a little bit of time on belantamab mafodotin, just to share with you that studies are ongoing in this. This drug ran into a little bit of trouble on the regulatory side with its phase 3 study not showing the degree of benefit that was expected. There are multiple other phase 3s coming through, which I think will establish its benefit. But nonetheless, it got accelerated approval, which unfortunately was held back after this phase 3 results came through. But I do want to stress, I personally believe that we will be back on track with this antibody going forward in the relatively near future. And why? Because whilst it's extremely potent in preclinical systems, it translates clinically into real benefit. And at the same time, some of the side effects that we've become challenged by, which was particularly the keratopathy, we've been able to fix by not only reducing dose and frequency, but also by adding nirogacestat, which is an oral agent that simply upregulates the BCMA. We've been able to show that you can use lower doses of belantamab less frequently with fewer side effects and much less ocular injury, which is always reversible anyway, but annoying and obviously can be challenging. Now with this approach, this is showing great promise going forward as an exciting new direction. Now, you've heard a lot about CAR T therapy, and I simply want to emphasize what I consider is such an important breakthrough, realizing that it is, of course, a highly selected or selective process, but nonetheless one where we're getting greater availability. And you've heard very nicely from Adam about all the promise around these platforms. And obviously for younger patients, this could be particularly exciting, but also for older patients too. CAR T platforms can be very useful. And there are multiple approaches under study, but just to emphasize, obviously, that we have the ide-cel platform improved, and I especially want to acknowledge Nikhil's leadership in developing and getting this drug to approval. And then also to emphasize there's a second one, so-called cilta-cel, which has been also very exciting with great response rates and very powerful in terms of its effects. But unfortunately, some of its side effects can also be a little challenging, but nonetheless, a very exciting and dramatic advance. Now, before going further on the CAR T space, I just wanted to emphasize that I personally think the value of CAR Ts will be bringing them earlier. And I think we may see much better outcomes, and we may also see much less toxicity coming sooner. And what's exciting is that these platforms are becoming more available. So for selected patients who are well enough to be able to have CAR T therapy, I think this is a very important advance, as you've heard so nicely from Adam and others already at the symposium. Now, what about other approaches that are perhaps not so quite immune-based? Well, one to emphasize is that of XPO1. This is basically the selective inhibitor of nuclear export proteins, or SINEs as they're called. And this is a very important mechanism in tumor biology. If you have too much XPO1, this enables cancer cells broadly to do a lot more damage and be a lot more difficult to treat. If you inhibit them, you can actually stop the transmission of key proteins that allow the cancer cell to function. And in myeloma, we've been able to demonstrate that this particular pathway has three core mechanisms that if we can reverse them, we can actually engender really dramatic effects on the pathobiology of the disease. So in that regard, the first orally bioavailable inhibitor of this pathway is so-called selinexor. Now, when you combine it with other drugs, it's highly synergistic. Now, it's not an easy drug to give. It has significant side effects, which you have to be very careful with. But once you've got on top of them, and especially in combination, this drug can be very active. And this is an example of selinexor combined with bortezomib and dexamethasone. And we were able to demonstrate in this study real benefit, in particular to patients with what we consider high-risk disease, such as 17p deleted disease. And even in older, frailer patients, as long as you use lower doses of this drug, you can actually achieve excellent outcomes. And multiple combinations are currently under study. But what's important to note is that with lower doses of selinexor, 40 to 60 milligrams once a week, combined with other drugs, we're seeing really dramatic results. What's also very interesting is there is a next generation selinexor now in development, which we believe may have fewer side effects, make you feel less fatigued, have less GI type of disturbance, and by so doing, bring greater efficacy to treatment as a result. Now, what about the peptide drug conjugates? Well, melflufen is a very interesting drug, in my opinion. This is what's called, and I use a metaphor, a Trojan horse. What this does is it gets into the cancer cell, and when it's inside the cancer cell, it's activated by a key protein pathway called the peptidase pathway within the myeloma cell, which is heavily overexpressed in myeloma. And when that happens, there's rapid uptake of the drug into the myeloma cell. The peptidases cleave the cell, the drug within the cell, and allow the payload, the warhead, to deliver where it's supposed to go, and it kills the myeloma cell. But why it's a Trojan horse is it's not activated outside of the myeloma cells, it's only activated within it, which is so important. The other thing is, just like the Trojan horse, it's not just that the Greeks go out and do their damage to the Trojans, it's they also open the gate. It allows more of the melflufen into the cell. So it leverages obviously melphalan as the warhead, which we realize is a very powerful tool, but it makes it highly targeted and just within the tumor cell. And what's so interesting is that it also targets what we call not only nuclear DNA, but also mitochondrial DNA. And this means it's able to overcome within the tumor cell some of the key resistance pathways, including 17p, that can make myeloma pathobiology so difficult. And so did we get the drug initially approved? With the Horizon trial, in which we showed in patients who had no other treatment options that about a third of patients responded, including those with so-called extramedullary disease. It was generally very well tolerated without too much in the way of side effects. And in fact, very importantly, apart from low blood counts, very little else was seen. A randomized trial followed, the so-called OCEAN study, and a little bit like the belantamab trial that resulted in some of the difficulties I talked about earlier for belantamab, the same difficulty ran into with the OCEAN study, where the melflufen dexamethasone arm performed generally better than the pomalidomide and dexamethasone, but in particular subgroups, there were problems. And specifically, what we were able to show here is that if you'd had a transplant and you gave melflufen close to a transplant, there the benefit was not as great as was expected. And most importantly, pomalidomide in particular performed much, much better. So that's illustrated here. However, if you hadn't had a transplant, then in fact, the melflufen performed really well. And this was the overall result of the study. And as a result of that, if you looked at the subgroups, you're able to show that those who were older and frail got substantial benefit from the melflufen, whereas those who were younger and post-transplant got much more benefit from the pomalidomide. And so this particular trial, of course, is a landmark study in the sense that it shows the importance of subgroup analysis, but at the same time, in the same way as belantamab mafodotin ran into some difficulties in exactly the same head-to-head design, we're beginning to realize we have to be perhaps a bit smarter as to how we interpret subgroups and realize that certain groups of patients may benefit from other drugs, but not from this, not patients who are in different subgroups. And one perfect example of this is illustrated here. This is venetoclax. It's a selective inhibitor of BCL2, and if you have translocation 11-14, this drug really works well. But if you don't have 11-14, it doesn't. So as a result of that, the Bellini trial, which was an approval finding study, had been launched. And unfortunately, for those patients in the study who were T11-14 negative, the clinical benefit was not clear at all. In fact, it may have in fact done more harm than good. As a result of that, the development of the venetoclax is now laser focused just in the 11-14 population. And in that group of patients, we're hopeful that we'll see clinical benefit and lead to the approval of the drug going forward, because certainly if you're 11-14 positive, it helps, recognizing that if you're not 11-14 positive, unfortunately, the benefit does appear to be very little. So the last few minutes, I wanted to touch primarily now on the exciting new drugs in addition to those which we've already touched on. I want to spend a little bit of time first and foremost on what we call the CELMoDs, and also touch on what we call the degraders, which are very much in the same family. Here you can see how these drugs work. They target proteasomal degradation of key substrates that control myeloma pathobiology. And these substrates are so-called Ikaros and Aiolos. They're key transcription proteins. And basically what we've been able to do is build a molecule that actually is different to the IMiD class. And by binding in this key pocket as what's called the cerebron E3 ligase complex, it generates dramatic changes in the way the tumor cell behaves and the cytokines around it behave. And the first one in the family, iberdomide, has shown really nice benefit and clearly has showed improved outcome in pomalidomide refractory patients and is going forward. There's an even more powerful one, so-called mezigdomide, which we christen Mezi for short. And again, please don't worry about the details, but please just know that it is a different molecule, it's a much bigger molecule than the immunomodulators, which are these much tinier small molecules. But this one really is a bigger molecule that engages this pocket in a very different way. And as a result of it, results in a very substantial increase in Aiolos degradation efficiency. And this overcomes lenalidomide and pomalidomide resistance. The same effect is seen from other classic degraders, which are in slightly different families. And we're studying those too, and we think they're very promising as well. In any event, what do we have so far for treatment effects? Well, so far so good. In our first study of mezigdomide plus dexamethasone, we showed a very nice response rate of around 55%. And this was a small number of patients, so we had to be careful. But these were heavily pretreated, really refractory patients for whom no other meaningful options existed. It was just a pill. And so given 3 weeks on and 1 week off, to get 55% in this population, we thought was pretty exciting. At the ASH meeting in December, we presented our results for a much larger cohort of patients, 101 strong, summarized here. And the good news is the treatment emergent side effects were very manageable, and importantly, just centered around low blood counts. But as you can see here, a lot of zeros in the serious column, pointing to the fact that this drug was otherwise very well tolerated. And then when we looked at responses, this to us was remarkable. Just for a pill, if you had all drug classes unfortunately fail you and you're in unmet medical need, 41% of patients responded. They had extramedullary disease, which is a real challenge, and all these other classes of drugs have failed the patient. We got a response rate of around 30%, which is still a very good starting point. And then when you look here at the patients who've been exposed to BCMA therapy, it was even more exciting. You can see a 50% response rate. So in other words, those patients who had already had CAR-T, bispecifics, or belantamab mafodotin, recognize the majority were actually belantamab mafodotin, it has to be said, but nonetheless, there were CAR-T and bispecific patients in this cohort. The response rate was 50%. You may say, this is amazing for a pill. Well, what is this? Why is this occurring? Well, we were able to do some correlative science, and I just want to especially acknowledge our patients who contributed to this, because in fact, this is one of our patients who kindly allowed a bone marrow aspirate to be done a week into treatment. And what you can see here for this patient is that previously, this patient had been on a triplet of isatuximab, pomalidomide, and dexamethasone. And at the start of treatment, ALOS was markedly upregulated, even though pomalidomide had just been used. When they were a week into treatment with mezigdomide, you can see that the ALOS degradation was dramatic, which is really interesting because it would not be expected. It would have been expected to be much more resistant. And in fact, that's not what we saw. And indeed, if we looked overall and across the whole study, you can see that even if you were POM refractory or your disease was pomalidomide refractory or pomalidomide was part of your last regimen, all of these cellular components were uplifted by the addition of mezigdomide, even though they had been previously pomalidomide refractory. So this was a very exciting outcome. So these were our conclusions, that mezigdomide was a very exciting new advance in this area, and combination strategies are ongoing, which is obviously very important. Now, I want to mention very quickly the bispecifics, because you've heard a lot about them, and I certainly don't want to dwell on what you've heard so nicely already, but just suffice to say, very exciting new platforms that have really gone a long way to improving outcome in the relapsed refractory setting. Teclistamab, most recently approved, which was very important. Elranatamab is coming as well, which we think is equally very important. And then we heard a very exciting study called about talquetamab at the ASH meeting, which had just been published in the New England Journal of Medicine. And this targets a target called GPRC5D, really important target developed by Eric Smith, who we're so lucky now to have in our laboratories working as a leading scientist. What Eric had shown from this target is this could be very important, and is clinically translated into what you see here, published in the New England Journal. It was so important. Now, the good news is all of these are going forward with a whole bunch of new studies showing that even if you've had prior BCMA, the use of the talquetamab platform can be effective. So a really exciting new area. And I especially want to acknowledge Jacob Laubach's leadership of our cevostamab work. This is targeting another receptor called FcRH5, and there we see very exciting results. Then finally, there's the immunoconjugates. This is a really very interesting targeted approach. I especially want to acknowledge Omar Nadim, who's been our leader in this field. And what you can see here is that you use an antibody that targets CD38 to attach to it an interferon in this case, and it results in really dramatic effects against the cancer. When you see here these response rates, this is all outpatient. It is not requiring hospitalization, and it's just an infusion. You can see very nice response rates around 60%, and these appear very durable. So we're very excited about it. This is so-called TAC573, or it has a slightly unpronounceable name, so we'll just call it MODA for short, because it's actually very active and generally well tolerated. I want to close now by just touching on a case, what we're all about, our patients. And this is a lovely patient of ours who we've had the privilege of looking after for 18 years. And she has benefited from novel therapies throughout, as you can see, for various reasons. She was probably she had other intercurrent medical issues that precluded her from doing a transplant early. So if we did not do that. We kept it in reserve. And she's benefited from sequential novel therapies. And she also got 2 years from melflufen, interestingly enough, of disease control. And then most recently was on just the drug that I was alluding to. And you can see here that she enjoyed a very nice response to TAK-573. And whilst she's now actually completed that therapy because she's run into some intercurrent unrelated issues, this exemplifies why these new drugs are so exciting and so promising. So these are my conclusions. First and foremost, I've taken you through an awful lot of information, but what I really wanted to emphasize is that all the new classes of drugs that we've had have made significant impacts on patient outcome and improved them. Immunotherapies are really this true amazing next wave, which seems to be really changing things. And however, whilst the immune therapies, of course, are so preeminent now, the good news is that we also have very exciting small molecules and other targeted approaches that really, I think, will add to the benefits that we see. And of course, with all of these options, we can tailor our therapy to benefit our patients and give them the best quality of life. And I think I'll close with one last case we heard so beautifully earlier from Jim and Kathleen about their journey. I want to share with you another one of our favorite patients who has been given her express permission to share her story with you because it's so, in my view, inspiring. And she's very comfortable also sharing with you her first name, Debbie. And Debbie basically started her journey with us in 2009. She had high-risk myeloma. She initially had a transplant, which didn't last very long, unfortunately. It only benefited her for 1 year. But then after that, she got a number of exciting new treatments that disease controlled. But then back in 2013, even though her disease had behaved very aggressively, she received daratumumab at that time as part of the phase 1 trial that we were running. And I want to especially acknowledge my partner, Jacob Laubach, who was our site principal investigator. And what you can see here is that in the context of her treatment, she is now 10 years on daratumumab in complete remission. And she's obviously become a grandmother ×3. And these are pictures that she's very graciously allowed us to share to illustrate the point of the quality of life she's enjoyed during that time. So I want to close by just saying an enormous thank you to you, and especially acknowledging our fabulous clinical research team, which is here. You heard beautifully about our lab team from Ken. We're blessed to be partnered also with a wonderful clinical research team, which is, and everyone is included here. I want to especially then close by thanking you for your kind attention, and we look forward to the Q&A session that Ken and I will be hosting for you shortly. Thank you very much.